Hi, good evening. Apologies that I can't be with you in person tonight. My name's Junaid Bajwa. I'm a GP in South East London. Work 1.5 days a week as a GP, and the remainder of my time I support the CCG in Greenwich with business intelligence and mental health activities. This evening's presentation is primarily around my interest in IT and data, and hopefully some of the information I'll be able to share with you will help you in your individual roles. As most GPs, I have taken on a number of different roles in the system, both at a local, regional, and national level. Um, and my reason for taking on these roles is really to support me in the consultation that I have, in the 10-minute consultation I have with my patients, so that I can enable them to self-care as best I can, and I can support them in some decision making. I think often we blame different parts of the system, but if we were aware of the rest of the system, aware of what our royal colleges do, aware of what our political bodies such as the LMC and BMA do, and aware of what the commissioning constraints are, we would be able to both change our own clinical behaviours and also change our patient behaviours as needed as well. So the main things that iBehave have asked me to look at with you today are: what types of information do GPs hold about patients? A little bit about the summary care record. What are the platforms where data could be used to help people make healthy choices? And how could data help GPs make better diagnoses and influence their patients' choices? So just taking on the first one, in terms of what information do GPs hold about patients? So I guess the first thing to think about is what are the systems that we code on. Primarily they fall into EMIS or EMIS Web or EMIS LV, INPS Vision, System 1 and iSoft. And it's important to remember that this is within hours, so within the hours of maybe 8 to 8, 5 days a week or 7 days a week in walk-in centres. And out of hours is a different system that we have, and many out of hours providers use a system called Ad Astra. Most of what we do is coded information, but we also free text within the systems as well. What we read code are around the demographics. It's really important for us to keep up-to-date contact details so we can help inform patients of public health activities. We code medical conditions and their medical histories. What do we do within the consultation in terms of their examination, what allergies they may have, what medications they're on, what immunizations they've had, what interventions have we done or have been done on them by the hospital. We would have any letters, emails, faxes onto our systems as well, from hospitals, from mental health institutions, from social services, any information really that's pertinent to their health and well-being. Summary care record. Essentially, it's just a very headline summary which can be used by hospital or out of hours providers to better manage patients in times of emergencies. The information is quite limited at the moment, limited to the medicines and the allergies they may have, what their name is, their date of birth, the NHS number. Additional details can be added, but it's at the patient's discretion. What are the platforms where data could be used to help people make healthy choices? I think the first thing to think about, and just to orientate you around this slightly busy slide, is that we do have a health pyramid. We have patients at the very tip of the health pyramid who are high-risk patient groups. And these are patients that are bouncing in and out of hospital a lot. The typical provision for them is around A&E, inpatient care, trying to do case management for them, maybe even palliative care. And the aim of the services are around reducing readmission rates and reducing length of stay. Moving towards the bottom of the pyramid, we have patients who are the general population, so our low-risk patients. And around for them, what we should be doing is identifying patients early, preventing them from developing chronic diseases and promoting healthy living, and controlling any risk factors or recognizing risk factors before they come to the surface. Primary care sees patients across the whole pyramid. And in terms of changing behaviors, I wonder whether we need to really focus on the bottom part of the pyramid as best we can, as the higher up we go, the harder it is to change their behaviors. And the opportunities, therefore, in terms of changing behaviors, lie in this spectrum here. Historically, arguably, it's been public health that's been looking at the bottom part of the pyramid, and as public health now moves into the local authorities, we wonder what should we be doing as primary care health professionals in terms of managing some of that risk. Our general model in medicine is around diagnosing somebody with a problem and then treating them with a prescription drug or referring them to an appropriate service. What we haven't been trained to do at medical school is try and recognize patients at risk and preventing them from developing conditions. So having that conversation about nutrition, having that conversation about exercise, having that conversation about health and well-being activities is not something that we've necessarily been trained to do, but it is something that we should be doing. How could data be used to help GPs make better diagnoses and influence their patients' choices? I really wanted to just share with you what a typical day in general practice looks like. So if you have a look at this right-hand side first, each mini red box is a 10-minute consultation. The yellows are my catch-ups and the greens are where I would do telephone encounters. The blues are where I would do home visits and the grey is where I would do admin. 16 or so patients in the morning, 16 or so patients in the afternoon. Generally 4 days a week. People often ask what did I do on Thursdays, and this is where I would do some professional development activities. There would be anywhere between 75 to 100 letters, posts, faxes, emails to look through. Do maybe 2 to 3 home visits per day, so it's a busy packed day. On top of this, the contract forces us to look at things such as QOF, which is the Quality and Outcomes Framework, LES's Local Enhanced Services, DES's Direct Enhanced Services, CIS's Commissioning Incentive Schemes, additional services that we may be offering in the surgery, make sure that we have child protection in place, engage with something called the Gold Standards Framework for patients at the end of their life or with complex needs, make sure we have appropriate information governance in place, engage with the Care Quality Commission, make sure we have a patient reference group who acts as our executive and we run big decisions by them, make sure we have in-house practice meetings, meet all our key performance indicators, engage in audit, engage with public health, engage with CCG, and try and motivate patients to change their behaviours. In those 10-minute consultations, we would be managing chronic long-term conditions such as diabetes, heart failure, managing suicide risk, managing depression, and you can imagine that the pressure is really on in here. And so what we need to do is see what can we do to perhaps improve access for patients alongside this, perhaps to make life easier for GPs and primary healthcare professionals, and maybe even try and enable patients to self-care as best they can in the system. And going again to a comment I made earlier, which is at the moment what we do is diagnose and treat. We probably need to move to a recognize and prevent model if we're really going to try and influence that change in behavior for both clinicians and for patients. And the question around how can we use data to make better diagnoses, influence patients, I think it depends on which lens we're looking at and which organization is looking at their data and what their drivers are. So if you think about GPs, their drivers are around QOF, around improving access and ensure that there's a safe service that they offer. It may be about better prescribing. It may be about identifying at-risk populations and tailoring health services for them, and indeed identifying high-risk populations and case managing them. Where they would look at data and who they would look at is for their registered population. From a CCG's perspective, they look at qualities, they look at outcomes for patients that they serve and for safety. And a CCG would use that information to inform commissioning decisions, but a CCG cannot use patient confidential data. And it looks at the total population perspective. And I guess it's just as an addendum to this, a CCG doesn't hold a GP contract. The GP contract is held centrally by NHS England. And one of the challenges that CCGs have is around patient confidential information. And this document to the right-hand side, which is the Information Governance Review, or also known as Caldecott 2, has limited the amount of information that CCGs can actually utilize in terms of using patient confidential data to inform some of their commissioning decisions. What does exist in the system now are different league tables, different comparison websites for practices and GPs to look at their own individual practice and compare it to others. Yet you can imagine if we're already drowning in work, referencing you to the previous slide, it can be actually quite difficult for us to take the time out to reflect on our own practices and the practices of those around us. But this is available to practices in London, so the GP Outcomes Framework dashboard and the King's Fund data repository. Thank you very much for your time, and again, apologies that I wasn't able to be there with you in person, but if you have any questions, I'm very happy for you to email me at junaid.bajwa@nhs.net. Thank you again. Have a good night. Bye-bye.